and welcome to this Retire Safe video focused on discussing health disparities related to seniors. In this video, we will talk about what health disparities are, what factors influence health disparities in general, and what aspects of health disparities are directly correlated to seniors in America. Sit back, relax, and enjoy this educational video and learn about health inequalities and what you can do to protect yourself and get the most out of your healthcare.
What exactly are health disparities? According to the CDC, health disparities are preventable differences in the burden of disease, injury, violence, or in opportunities to achieve optimal health experienced by socially disadvantaged racial, ethnic, and other population groups and communities. Health disparities exist in all ages, including older adults. Even though life expectancy and overall health have improved in recent years for most Americans, not all older adults are benefiting equally because of factors such as economic status, race, and gender.
To address the contribution of these factors to health disparities related to aging, the NIA has supported research, for example, that found Alzheimer's disease to be more prevalent among African Americans and Hispanics than among other ethnic groups in the U.S. Other studies have found that lower socioeconomic status is associated with poorer health and reduced lifespan in the U.S. Scientists have also observed sex differences in health and longevity. For example, overall women live longer than men, but are more likely to develop osteoporosis or depressive symptoms or to report functional limitations as they age. Men, on the other hand, are more likely to develop heart disease, cancer, or diabetes. Social and environmental factors such as residential segregation, discrimination, immigration, social mobility, work, retirement, education, income, and wealth can also have a serious impact on health and well-being. Income and wealth are extremely important when it comes to factors that impact health disparities, especially regarding seniors. Economic circumstances can determine whether an individual can afford quality health care and proper nutrition from early life into old age. Individual and family financial resources and health insurance often determine whether an older adult enters an assisted living facility or nursing home or stays at home to be cared for by family members. This brings us to the biggest factor for seniors surrounding disparities in healthcare: health coverage.
Disparity in access to healthcare services under the mixed private and public United States healthcare programs elevates inequality of health and health status among older Americans. For example, in order to even qualify for Medicaid or Medicare, an individual must meet certain requirements. If you do not meet these requirements, then you're not eligible and are forced to either purchase private healthcare coverage, or for those who do not qualify for Medicaid and Medicare but cannot afford private insurance, you fall beneath the cracks into the uninsured population. For Medicaid, you may qualify for free or low-cost care through Medicaid based on income and family size. In all states, Medicaid provides health coverage for some low-income people, families and children, pregnant women, the elderly, and people with disabilities. In some states, the program covers all low-income adults below a certain income level, but this varies from state to state. To be eligible for Medicare, you must be approved as medically needy, which means your measurable resources must also be under the resource amount allowed in your state. We will go into more depth about these requirements and disparities on the next slide.
Medicare benefits consist of two parts: Hospital Insurance Plan Part A and Physician Insurance Plan Part B. A person with hospital insurance protection, Part A, may have benefits paid on his or her behalf or in certain cases paid to him or her for covered healthcare services. Part B adds an additional protection by providing a basic hospital insurance plan and covering a substantial part of physician services in both hospital and non-hospital settings that include an emergency room or outpatient clinic, including same-day surgery, ambulance services, and clinical laboratories. Parts A and B are provided automatically to a person age 65 or over who is entitled to Social Security retirement benefits and is qualified for Medicare. You usually don't pay a monthly premium for Part A coverage if you or your spouse paid Medicare taxes while working for a certain amount of time. This is sometimes called premium-free Part A. If you aren't eligible for premium-free Part A, you may be able to buy Part A at a specific cost depending on your state. Beginning in 2006, an additional plan, Part D, has provided subsidized access to prescription drugs insurance coverage. Part D is financed primarily through premium payments and contributions from the Treasury General Fund. Part D works differently from Medicare Part A and Part B, beginning with the fact that Part D is an optional plan. However, those eligible need to choose among plans offered by health insurance providers or other companies approved by Medicare, which can pose as an obstacle when certain pharmacies and physicians are out of network or certain drugs, specifically antibiotics, are not being covered by insurance. Any person who enrolls in either Medicare Part A or Medicare Part B is eligible to enroll in Medicare Part D, but this does not guarantee that you will be covered. If qualified individuals do not enroll in a plan when they first become eligible for Medicare, they might be subject to a Medicare-imposed late enrollment penalty. The other aspect to insurance is the private health insurance company. There are many types of private health insurance coverage that seniors can purchase in order to fill the gaps that are not covered by Medicare. These types of private health insurance/coverage include employee or retiree coverage from employers and Medigap insurance from private insurance companies. The supplemental insurance pays for parts or all of healthcare costs. These types of private health insurance coverage are known as supplemental insurance. Medicare supplemental or Medigap insurance is a specific type of private insurance that is subject to federal and state laws. Medicare supplemental insurance policies are sold by private insurance companies to Medicare beneficiaries in order to fill the gaps in the original Medicare coverage. There are 10 standardized policies labeled Plan A through Plan J that work in conjunction with the original Medicare plan. Each state decides which of the 10 policies can be sold in the state. Since Medicare does not cover all healthcare expenses, Medicare supplemental insurance is only sold as a supplemental health insurance for Medicare recipients. Unlike Medicare, Medicare supplemental insurance plans is not a federal program. However, health insurance companies that provide Medicare supplemental insurance coverage are strictly regulated by both the federal and state governments, which can pose as an obstacle when it comes to certain coverages or expensive treatments such as chemotherapy.
You might be wondering, how do these different coverages connect to health disparities relating to seniors? Let's dive a little deeper into this.
Improving health status is a central objective of policies designed in the United States today, as emphasized in Healthy People 2020. One of the growing debates in health policy and strategy wages over how to eliminate health disparities. Policymakers often draw a distinction between access and utilization of healthcare services. Both types of health insurances influence the degree of health disparity caused by unmet needs and delayed care. The accessibility of healthcare services for an individual is defined as the availability of private and public health insurance, ability to procure and use knowledge, and other socioeconomic and demographic characteristics of the individual. The differences in these factors widen the disparity in health among children and older adults under the current U.S. healthcare system. The graph pictures show that 54% of people in the United States have delayed medical care in the past 12 months because they could not afford it. The most commonly delayed types of care resulting from a lack of money are dental or orthodontic work, 55%, eye care, 43%, and annual exams, 30%, all of which are listed under Medicare's list of items that the benefits may not cover. The infographic shows the extent of the problem by level of household income. Unsurprisingly, households in the lowest income bracket who are taking home $50,000 a year are most likely to delay or put off medical care for financial reasons. High-earning households bringing in $100,000 or more aren't immune to the problem either, with 40% of those polled putting off medical care for financial reasons in the past year. After looking into this research, the questions posed from the study are: 1. Do public health programs, such as Medicare and Medicaid, play an effective role in reducing unmet needs and delayed care? 2. How important is the difference of income disparity and out-of-pocket costs in determining the choices made in unmet needs and delayed care situations? And 3. What are the influences of predisposing factors such as education, patient trust, patient satisfaction, and patient-provider communication on unmet needs and delayed care?
This study, conducted by the NIH, concluded that unmet needs of prescription drugs for the elderly population have a positive influence on the perceived delay in healthcare and perceived unmet needed healthcare. These factors are disproportionately large in the population among the poor or low-income elderly. These three factors raise evaluated ill health status, ranging between 45% to 60% among the elderly population. Other findings are that out-of-pocket medical costs elevate perceived unmet needed health care and delayed health care, and the high out-of-pocket costs raise disproportionately large perceived unmet needed health care for elderly population. Although any of the three options for expanding coverage through the Medicare program would likely reduce racial and ethnic disparities in health insurance coverage, research has shown that disparities in access to quality care still remain for insured minorities, even within the Medicare program today. Among Medicare beneficiaries, research findings indicate that older adults of racial and ethnic minority backgrounds have worse health indicators and receive lower quality of care than whites. Within Medicare Advantage plans, a recent study found that beneficiaries in racial and ethnic minority groups reported experiences with healthcare that were worse than or similar to the experiences reported by white beneficiaries.
Medicare involves considerable out-of-pocket expenses for beneficiaries, including deductibles and co-insurance. And, unlike private insurance under the Affordable Care Act, Medicare does not cap these out-of-pocket expenses. Medicare also has gaps in coverage, such as for dental, vision, and long-term services and supports. People of color are less likely than whites to have supplemental coverage to cover these gaps, contributing to the less use of physician services than white beneficiaries. Here is a graph that shows the impact that the Affordable Care Act has had on different racial groups in America.
The following video explains how it is fortunate to have Medicaid in some states but not in others. Throughout this video, we hope that you will see the breakdown in coverage in the American healthcare system.
I got sick when I was a little kid. I was about 11 years old.
The United States has the most complex healthcare system in the world. It's our country's immune system, and like any immune system, it's not perfect.
My immune system doesn't know that my small intestine is a thing it should not attack.
That's Matthew. He lives in Massachusetts, and he has Crohn's disease.
Stabbing abdominal pain at like 2 o'clock in the morning. I had imaging done, CT scan, incredibly expensive IV antibiotic therapy. The worst experience of my life. I cannot imagine the stress that going through that experience and not having health insurance would have caused.
Matthew is one of the 70 million Americans, 1 in 5, who gets his healthcare paid for by Medicaid.
Without Medicaid, without access to really good medical care, I wouldn't be alive. Medicaid paid for all of those things.
But the thing about Matthew is, if he lived in a different state, he might not have Medicaid. This state-by-state inequality is baked into the Medicaid system and the American health system at large. We hear all the time that
we spend more on healthcare,
far higher healthcare costs than any other developed nation, any other developed country, and the results are worse.
But that's an average. There are many states that have great outcomes. States where life expectancy, infant mortality, and preventable hospital admissions look like European countries, but not every state. If you look at the states below the US average, those with the lowest life expectancies, the highest infant mortality rates, and the most preventable hospital admissions, they all have something in common. A sizable portion of their population doesn't have health insurance. Regardless of what you see on TV, the most life-saving medical care in this country isn't sexy. It's the regular medical care you get when you have good, affordable insurance that saves more lives. Most countries around the world improved their citizens' collective immune system with a universal health program. But America has always been a bit different.
The right to adequate medical care and the opportunity to achieve and enjoy good health.
FDR's New Deal to help the US beat the Great Depression in the early 1930s focused way more on unemployment and Social Security than on health care. And there was a reason for that. The American Medical Association, the largest trade group for doctors, lobbied hard against any form of national health insurance whenever FDR proposed it. So he and his administration let it go. And when they did, private insurance companies stepped in.
Private insurance really grew rapidly through the Second World War because there were federal wage freezes and there was a labor shortage.
To fight this war, 10 million more people must go to work by the end of 1943.
So you're an employer and you're having a hard time hiring people and you're not allowed to offer more money. So what you do is you sweeten the benefit package.
But in other countries like Great Britain, private employer-based health insurance didn't really develop. And before it could, the government began offering health care to its citizens through the National Health Service, or NHS.
This new health service will be organized on a national scale, and so everyone will pay for it, and everyone will benefit from it. When you're ill, you won't have to pay for treatment.
But not every European country created a single-payer system like Britain's. As in the US, private insurance companies cropped up in Germany and France, but unlike the US, those countries regulated these companies closely. They had to operate as nonprofits, they had to cover everyone, and they couldn't refuse to pay for something. American doctors and insurance companies didn't want to see this type of system limiting their profits.
The percentage of Americans that had private health coverage just ballooned from about 1938 to 1950. And that's when doctors started to get rich, the physician community.
I got sick when
So how do we combat this issue? Policymakers need to address a diverse amount of issues to make healthcare more affordable and accessible to reduce inequality of healthcare burden. Research results are compatible with the result by Hispanic and African American behavior of unmet needs in delayed healthcare. It is known that economic and financial aspects are debilitating factors for the elderly population, falling in the group of delayed healthcare and unmet needed healthcare as a regular source of care. In other words, it implies that income and out-of-pocket medical costs are associated with the two characteristics. The income factor is inversely associated with access disparity and health inequality, whereas the out-of-pocket medical cost has a positive association, or a direct association, with the access disparity and health inequality. To have a larger impact on reducing racial and ethnic health disparities, the underlying factors that contribute to health disparities, lower quality of care and financial barriers to care, would need to be addressed in any program that expands access to Medicare coverage. Even if a Medicare for All program could eliminate the gaps in coverage and remove many of these financial barriers, the novel program would also have to address other causes of health disparities, such as housing availability, neighborhood conditions, food insecurity, and educational opportunities. Stay aware of the policies and what is being discussed on the Hill. These bills and policies could impact your health coverage or the coverage of a loved one or someone you know, and it's better to be in the know than be surprised. Be cautious about all of your spending when it comes to healthcare. Surprise billing affects many because they were not properly informed on what they were signing or spending their money on. And lastly, don't be afraid to talk to your primary care provider about the right options for you and your wallet. There are options for everyone, but it takes time and patience in order to find the best route to care for you.
We hope this presentation helped you better understand what health disparities are and why we at Retire Safe believe our members should stay aware of the changes regarding our healthcare system. If you have any general questions about health disparities and the factors of influence remaining, please contact us at contact@retiresafe.org or visit our website at www.retiresafe.org. And if you would like to stay up to date on the latest news and issues relevant to you, as well as updates on what we at Retire Safe are doing for our members, please consider liking us on Facebook and following us on Twitter. Thank you very much for listening, and we here at Retire Safe hope you have a pleasant and safe day.